Hello, everyone. Welcome to NMQF Live. And I'm so pleased to be here. My name is Audra Chamating. I'm Vice President of Communications and Public Affairs at National Minority Quality Forum. And you are here joining us for this conversation about Medicare coverage for obesity management medications. And I'm so pleased to introduce to you all our wonderful speakers and panelists today. First, I would like to introduce Dr. Virginia Kane of the National Medical Association. Hi, Dr. Kane, how are you?
Well, how are you? Nice to see you again.
Yes. And then I'd also like to introduce Dr. Ray Serrano of RULAC. Hi.
Hello. Now you can
And
hear
last
me.
but not Last but not least, we are so pleased to host this LinkedIn Live in collaboration with blackdoctor.org, a phenomenal platform that I'm sure most of you are aware of. And maybe you don't need this introduction, but we're so pleased to have Sherry from blackdoctor.org with us here today. Hi, Sherry.
Hi, Audra. So grateful to partner with the National Minority Equality Forum and Dr. Kane. Very honored to be in a conversation with you as well as Dr. Serrano. Thank you for having me.
So if you haven't heard the buzz about obesity medications, they go by many names. You might have heard of Ozempic, you might have heard of Wegovy, and we're here to talk about them all. We're here to talk about the clinical impact. We're here to talk about how it's transforming lives, but most importantly, as the title of this event suggests, we're here to talk about acting to advocate for coverage of these obesity medications. And there's an important date coming up that is January 27th, which is the deadline that CMS, which is the Medicare agency, put as the end of the public comment period regarding a proposed rule to have Medicare cover obesity medication drugs. So we're going to include a link in the chat box. And in the meantime, we encourage you to post your comments, post your questions, and our team will answer them as this live continues and our discussion continues. So really encourage an interactive conversation here. And please, please, please make sure that you share the link that we will share shortly regarding how you can participate in this advocacy opportunity for obesity medication management drugs. At this time, I would like to pass the mic to Sherry of blackdoctor.org to introduce blackdoctor.org to you, which is such an important collaboration for this particular discussion. Sherry?
Honored to go first. Thank you so much. I'm a patient as well. I mean, I'm on the obesity drug, and it's changed my life. So thank you to the pharmaceutical industry for giving us this gift. It's a life-changing experience for me. So, that's number one. Blackdoctor.org, as you might know, reaches millions of the Black community in the U.S., and we need to change more lives. So I'm really happy to be here. And the goal really is to stress the urgency of everybody's voice matters. We need your help at this point for public comment, which we'll talk about today, but really now's the time to use your voice. So I'll let the others introduce themselves, but that's why I'm here today. Thank you so much.
Thank you so much for that. And we know that blackdoctor.org is also live streaming on their platforms as well. So if you are joining us from their platform, hi, please make sure to comment as well and submit your comments and questions. So why is this such an important conversation? Why is National Minority Quality Forum activating all of its resources? Why are all of these very important people spending time to talk about this today? Is because we certainly want to talk about obesity in relation to communities of color. As you may know, communities of color experience higher rates of chronic diseases. Non-Hispanic Blacks in particular have, unfortunately, the highest prevalence of obesity at 49.6%, followed by Hispanics at 44.8%. And this is just higher than the average white person. And there are many reasons for this. Obviously, I'm sure you've heard of the term food desert or food apartheid. There are access issues. There are underlying conditions. There are many reasons why communities of color experience obesity at a disproportionate rate. And so it is imperative that communities of color, particularly individuals of color, have access to weight loss drugs, which is another term for these medications. African American women in particular have the highest rates of obesity among any demographic group. And we really want to ensure that we are approaching these communities in a non-stigmatizing way, in a way that supports a healthier future. And it cannot be understated at this point, not only the transformative impact of these medications, but the clinical impact in that we talked about chronic conditions, we talked about underlying diseases, that sometimes when you address weight, and you will see progress and change in the other conditions that a person might be experiencing. Um, and really, some folks might say, well, they should get in the gym or they should eat healthier foods. And we want to really stress the importance that weight loss medications are um, a remedy for a clinical disease, a clinical condition, and that it's a matter of a number of factors of why any particular individual might be experiencing obesity, and that these drugs help to target um, the clinical condition and experience for that patient in a way that enables them to perhaps also address other social determinants of health. Lack of insurance coverage is a major driver as to why communities of color are not accessing not only clinical care that could be addressing their underlying conditions, the chronic conditions that might be contributing to obesity, but also to the weight loss drugs themselves. And so that is why we're here today, because the Biden administration, in its last days, introduced a proposal to have Medicare and ultimately Medicaid cover weight loss medications. And this would be a transformative and breakthrough moment to address the lack of insurance coverage issue that has been a barrier for not just communities of color, but in general, those of lower income, those in other vulnerable populations, um, from accessing weight loss medications and its clinical promise. And so it was so important for us today in this conversation to have both Dr. Kane of the National Medical Association, the leading association for African American physicians and clinicians, and Dr. Serrano of LULAC to explain the clinical as well as the economic opportunities that um, this access to weight loss drugs present. And so at this point in time, I would like to pass the microphone to Dr. Kane to share her thoughts and her perspective about just how important it is for this proposal to become reality and how important it is for all of you to take action. Dr. Kane?
Well, thank you. We are an organization that's known for fighting for parity and the elimination of health disparities, especially social justice in terms of our priorities. Now, we recognize that 108 million Americans are diagnosed with obesity. In this country, we expect by 2030 that over 50% of this country will meet that designation. But unfortunately, for Black Americans, we've already reached that 2030 mark with 50% of our Americans diagnosed with diabetes. And definitely as a Black woman or African American woman, we're already at 55% diagnosed with obesity. But let's talk about how obesity impacts us in terms of health outcomes. It increases our risk for diabetes. It impacts us in terms of increasing our risk for Alzheimer's. It impacts multiple cancers that we can be predisposed because of our obesity. Or because of the diabetes, we have some of the highest limb amputations related to that. So we can see high cholesterol, related to this condition. And it can even impact infant mortality in a fashion because of the obesity with significant outcomes. And so if we have some special medications that can reduce cardiovascular disease. Heart disease is the number one killer in this country, no matter what race, but it's definitely the number one killer for Black males and Black females, and significant disparities for Hispanics. So some of the studies have shown that some of these weight loss medications can reduce a heart attack by nearly 28%, rounded off to 30%. Can you imagine what it means to reduce a heart attack by nearly 30% and possibly strokes by 7%? Let's think about this. The average Black male's life expectancy is 68 years of age. Life expectancy is 68 years. So if I had the ability to maybe reduce heart attacks by 30%, can you imagine the longevity we could see related to these weight loss medications? And we already have the Veterans Service, Indians Health Service, and others who are in federal employees already who have access to these medications. So it's so critical that all of our populations have a equitable access to the whole armamentarium of how we treat obesity, because we could reduce our diabetes substantially. We could reduce our hypertension and heart disease substantially. And so it economically can have a huge impact positively on our healthcare systems.
Thank you so much for that, Dr. Kane. You talked about the impact of weight loss with other conditions and what that means, and I cannot wait to delve into that further with you when we come together for our panel discussion. At this time, I would like to introduce Dr. Ray Serrano of the League of United Latin American Citizens, the largest and oldest civil rights organization for Hispanic Americans and Latinos living in this country. And you all have had such a strong voice on this subject. Can you tell us why, Dr. Serrano, this has been so important for LULAC and for yourself to advocate for?
Yeah, I think the issue for us is more of kind of, as Dr. Kane mentioned, it is a question that it's a burden that has fallen on our community. The numbers that we have for prevalence for Latinos is a little bit higher. It's at 47% for adults for obesity. It is second to African Americans, and then for children, it's very concerning because it's one of the, I think it's the highest. It is at 25.3% for children, which is interesting because it's more Latino boys that are obese than Latino girls. So that's a challenge that we're facing there. So we're really sadly we'll soon graduate to that 50% plus mark that are obese. And we're seeing that. And so we have a population of folks, 19% of the United States population, that is half obese. And I often use a phrase, the $1 million patients are about to become that $1 million patient. And what I mean by that is quite often you're categorized as obese, and with that comes the diabetes, the sleep apnea, the hypertension, the congestive heart failure, you name it, right? Like, and so in those conditions are quite often very expensive to treat. They're long-term. And so the premise of it is that kind of gatekeeping premise is really the obesity status of somebody. And I think that challenge is, if it's really a crisis, it requires the entire toolkit. We know, like, and I'll give you a story. I usually kind of try to humanize the stats because they can be just raw figures. But I often cite the story of my mother. Right, my mother was a migrant farm worker. I grew up in a migrant farm worker family. And she worked 2 jobs. She worked in the fields for 8 hours a day. She worked in the factory for 8 hours a day, 16-hour days every single day. By the time she was in her mid-50s, my mother her weight had gotten so uncontrollable, it was at 535 pounds. With that came the sleep apnea, came the hypertension, came the diabetes, came the congestive heart failure, came the whole span of things. And my mom was functionally that $1 million patient. Mom had 52 days of schooling. So the idea of understanding what good nutrition could look like, it was tough. Also, food deserts, fast food swamps. We lived within probably a mile from like a Burger King and a McDonald's and all that stuff. But to get fresh fruits and vegetables was probably another 5-10 miles to get to that. So you see that environment, combined with the health literacy, combined with the fact that, like, a lot of times, even when the city was planning new places for commercial things, we didn't, Latinos in my family included, we didn't know when the Planning and Zoning Commission was meeting. We had no idea that they were going to put some shopping center that was going to have a bunch of McDonald's and all these fast food places nearby, or that they were going to rezone a certain area that the grocery stores were going to leave. That was beyond our power. So then you have this situation where you have a very limited food supply or availability, combined with, and some families have issues of food shortages, so they have SNAP benefits. And in the neighboring, I live right here in DC, but if in the neighboring Maryland, which is a pretty wealthy state, either second or first most wealthy per capita state, the amount of distribution for SNAP benefits is $6 to $8 a day. I mean, a Subway sandwich here, a 6-inch sandwich at Subway would cost you about $8. That would be the only meal you would be allowed to have if they even provided for a fast food place to get food there with using your SNAP benefits. So the food availability. So what I see is it's kind of this pending kind of perfect storm of where you see a growing population of people who already are obese, limited access to healthy eating options, limited access to kind of health literacy, and then the limitation to the full health toolkit to really remedy this. And the outcome is going to be we're already seeing it. We're seeing the amount of rates of diabetes, ultimately feeding into life expectancy. I cite the story of my mom again. It's like my grandmother and my great grandmother who grew up in Mexico in a town with no running water, no electricity, lived up to 102. My mother's mother lived up to 109 in a similar situation with no running water, no electricity in Mexico. And mom, who was born here in the United States, largely raised here in the United States, dies at the age of 73. So 35 years younger. Like, to tell you that, like, it doesn't have to be that way. How is it that somebody who worked 16-hour days, who obviously wasn't lazy, how does that happen and convert into massive obesity? So the idea of we can change the course of that, it matters so much. And so I think for the Latino community, one thing that we do see quite often is the idea of engaging in policy. And policy is, it's to use the metaphor of diet, it's like, you have to nurture it. You have to stick to it. So if this policy changed on November 26th, to include anti-obesity medications in Medicare and Medicaid, that's great. It's a huge leap. We were testifying at state legislatures. We have about 535 councils across the U.S. in 33 states. And we were advocating at state legislatures. We were advocating on Capitol Hill. But this executive order or this proposed rule can actually really change up the game for things. But it also requires us to nurture that policy. We have to sustain that policy. And what we've seen in some states like Virginia, for example, that have passed included anti-obesity medications in their Medicaid formularies, you'll see them eventually trying to shirk that responsibility and say, well, let's increase the guidelines to this BMI, which is not adherent to clinical guidelines. And that requires us to go back to them and say, hey, hold on. Let's go with what the clinical guidelines suggest, because at the end of the day, we can't be budgetary discretion or budgetary just being arbitrary and trying to adhere to a budget doesn't necessarily coincide with what is clinically needed. And again, I can't stress it enough. So we've been telling all our councils to submit comments during this comment period for January 27th, just because it's important for Latinos to offer a voice to show how difficult it really is for our community if we don't speak out and if we don't try to sustain this policy.
Thank you for that. It is those powerful stories like what you've shared up with your mother and others in your community. That is why this public comment period is so necessary, because we've shared the statistics, we've shared the data, we've shared the clinical perspective, but at the end of the day, it's going to be the personal stories that move regulators and policymakers. Because I think one of the challenges with this whole conversation, and I'd love to know if you agree, is the perception of weight loss drugs that is somehow a concierge drug, a luxury drug, vanity drug, and the clinical value is often understated and not given enough attention. And you've shared all the reasons as to why those that need it the most, those who are often on Medicare or Medicaid, are the ones that are last in line to get access to the drugs that they need the most. And there's a saying that goes that what happens in Medicare happens everywhere else. Once we know that the weight loss drugs will be included in Medicare Part D, there's a downstream effect of it being included in Part B. It opens up the market with commercial insurance, also then providing more access to it as well. And so we will see just generally expansion of access to these drugs. And it's so necessary because we've talked about the clinical value, and Dr. Kane lightly touched on, the economic impact. But just to reiterate, obesity is choking this country. It's costing this country $1.72 trillion. And it's not even really covering the direct cost to individuals as they pay out of pocket for dealing with diabetes or the number of conditions that we've talked about. So, Dr. Kane, in your view, I would love for you to share what you think is the top, what you think clinicians feel as far as, how important weight loss drugs are to patients. Is this something that clinicians need to talk more about with patients? How, in your perspective, how is that conversation of obesity treated in the doctor's office?
So let's talk about the treatment for obesity. A lot of times, if you reach a certain weight level, we have surgical options that can be available with like bypass surgeries and whatever. But sometimes those surgical interventions can result in major complications. And so the weight loss medications is a wonderful a set of tools or options available in the treatment of obesity. And now, let me just make this clear. It's not the silver bullet, okay? So you just can't take the medications by itself and you ignore the lifestyle changes that you have to make, the behavioral modifications. So it's critical that you still have to do good nutrition. and learn what you should be eating and what you shouldn't be eating appropriately, like getting that proper fruits and vegetables, okay? Getting sort of the fatty acids that can help with your heart. So am I eating a significant amount of maybe fish or something like that I should eat during the week? And then, of course, you need the physical fitness, the physical activity that can contribute. So you need all of those things. But we know that if you lose even just 5% of your weight, you have improved health outcomes. And we know that with some of these medications, it can result in about 15 to 20% of your weight, and that can increase your health outcomes positively in a major way. So we just want to have all of the tools available in order to treat obesity, and everyone should have equitable access to all the resources that we can have to treat obesity, because if it can reduce heart disease, it can lower your cholesterol, okay, and it can cut down the development of diabetes, impact and decrease our risk for Alzheimer's disease, lower our risk for all these different cancers. Our providers need to be able to provide the best optimal treatment that they can in recommendations for our patients.
That's amazing. You talk about requiring all the tools in the tool bag to fight this. And I even, think again about the Medicare and Medicaid program, of which in often cases there are nutrition programs, there are fitness programs that are enabled through even some through commercial plans as well. But then it does seem that the weight loss drugs are the missing piece in this case, because we're talking about everything here, but we're not equipping patients with all of the tools that they can to have the changes that they need to have. And in a way, it can be a very frustrating experience, right?
Now, let me tell you one other thing, okay? So, and this is really critical, I think, for people to realize and understand, okay? So people's perception, will say, hey, if you eat right and you do the physical activity, you're supposed to be able to lose that substantial weight and not a problem. Well, we have a significant number of patients that even if they do and eat the nutrition right, even if they're doing that physical fitness and getting that activity in, may not be still sufficient in order for them to be able to lose that weight. And they may have something called like a resistant gene that's part of their gene that makes it hampers their ability to lose that weight. And so sometimes having these particular medications for those folks who are really resistant, they're doing everything right, but they're still not losing the weight, can be a wonderful resource to help them lose that 15 to maybe 20% of weight that substantially improves their health outcome, okay? It's just like a diabetics. People assume people have to be overweight, obese to develop diabetes. You can be skinny and develop diabetes. Yeah. And so it's all these myths that we're having out there and the stigma that can sometimes be associated with this. Hey, folks, we're trying to help you have the tools, but we do need to educate our clinicians and our healthcare professionals related to this availability of new resources as well.
That brings me to Sherry over at blackdoctor.org, because you guys are such an important information platform. How are you all educating about obesity? Are you talking to clinicians like Dr. Kane is saying, as well as patients?
Absolutely. Blackdoctor.org talks to many physicians and also patients who are taking these drugs, because access is number one. Like Dr. Kane has reiterated, that we need to make sure our community has access to to drugs that are going to save their life or help improve their health outcomes. So, when I talked to Dr. Kane the other day, and she told me obesity is one of her priorities, I was like, let's do this. It's so important for not only for us to tell stories and share our stories, but to make sure that everybody understands that their voice matters. We are at a critical time coming in. We're changing of the presidency, and now's the time for everybody to even take a moment during this conversation to go and use their voice. I mean, blackdoctor.org yesterday, we went to obesityaction.org. It makes it super simple for you to kind of sign on, voice your opinion about Medicare Part D, and say, here's my story and here's why I care. So, anyway, we do tons of education. Angela, yeah.
Yes, there's so many organizations coming together. Last year, we saw the Obesity Bill of Rights, which I believe many of you on this platform also signed. And so it's remarkable even that we've come to this point. This has been a long fight for many of us to see this sort of innovation become more accessible and equitable in its application. Dr. Serrano, you started to outline sort of what you saw as the fight ahead. And just again, reminder for everyone on this call that the link of which to share, to submit comments is posted in the comment section. And please pause even right now, maybe put us in the background and still continue to listen to us, and write your letter if you can, or share your link on your social platforms, because we need to get letters in by January 27th. So Dr. Serrano, back to you again. You started to outline the fight ahead. I mean, what do you see as the challenges? You've heard Dr. Kane say that this is not the silver bullet, but how important is it for this policy to come to fruition?
Yeah, so my background, I originally started in public health from the standpoint of HIV. And so I was working in HIV and worked overseas, and then kind of came domestically. And you would think you wouldn't really consider HIV and obesity to be kind of in the same category. But I, in many ways, the way I see it, it is. Because one, in 2013, the American Medical Association categorized obesity as a disease, right? But if you look at it in the standpoint of HIV, there's always a focus of how you got here. Oh, you must have got here because of bad behavior. You must have got here from risky behavior. You must have not taken the precautions for it. And then there's this idea of like, well, why should we pay for your poor choices? But then you ask yourself like a different question: how much choice do you really have, right? And if you're in certain communities, or if you're certain like demographic groups, how much choice do you really have? And so you're put in the situation where you don't really have that much choice, and yet you get this disease, and surprise, surprise, now they're stigmatized. And you're stigmatized with the disease, and you're stigmatized to even seek treatment for the disease, because everyone wants to focus on how you got it, right? And so for HIV, we had Ryan White, right, the little guy from Indiana, and he warmed our hearts. And Michael Jackson and Elizabeth Taylor, everyone came out, and we say, okay, let's have some mercy on HIV folks. We don't have a Ryan White in obesity world. We don't have. There's no African American or Latino story that tells us, oh, there's this person right here played all the rules, and yet they still came out this way. But we all know the stories all too well, right? We know the stories, a situation, as I mentioned about my mom, like, how does somebody who grows up in a place that has running water and has electricity die 35 years less than than folks who lived longer, like, or who lived in different circumstances? So that's a challenge that I think we find. But again, the sustaining the policy is going to be the big challenge. So big secret, before I started at LULAC, I used to work at CMS. I used to work at Center for Medicare and Medicaid Services. I worked on Part D and Part C. So I know a lot. I was the guy who was actually writing the response back when the notice of comment periods came back for the advance notice and the rate announcements and so forth. One thing we did pay attention to when you do get those comments, you do pay attention to how many comments come in for certain things. There's when you go report back to your supervisors, there's a buzz. You say there's a buzz about this issue. The people are commenting a lot about this issue. That buzz matters. It does matter. So our voices speaking out matter. We need to provide that voice for folks who don't really have the access to provide that voice. Folks don't even know there's some folks in our communities don't even know what CMS is, right? Those people, but they're affected by obesity, right? And they're affected by, and we shouldn't be settling for a life expectancy to 65. We shouldn't be settling for life expectancy. And there's some parts of, like in Maryland, the life expectancy is 20 years less. The disparity from the white community to the black community, 20 years less in the course of less than a mile. It's just the neighborhoods that you live in. That doesn't have to be that way. And so one thing is to provide those comments to CMS on this issue. And should the policy be sustained? And in the states, I can guarantee you that some of these folks in certain states, I wouldn't say red states, because Mississippi, red as can be, includes anti-obesity medications in their Medicaid formularies. Maryland, as blue as can be, does not, right? So it's not a red and blue state thing. But there's some governors that say, well, we're still, and it's crazy. Every governor wants to be, or a certain budgetary director wants to be a doctor and say, hey, like, I don't think we should be paying for this stuff. Okay. Would you say that about, should diabetics not get insulin? Are you going to say they made poor choices and therefore they should not get insulin? Should we say asthmatics should not be getting inhalers? Like, you wouldn't say that. But we so stigmatize this disease, and we want to assume that these folks need to have some punishment. That doesn't have to be that way. And I think sometimes people respond better. The way I make the argument sometimes is not so much of the cost of action, but the cost of inaction. Everything has a cost, right? You do this intervention, or you say, well, it's going to cost a lot of money. Okay, if you don't do the intervention, how much more will it cost you? Because those diabetics have to get insulin. They might have to have amputation. They might be on dialysis. How much is that going to cost you? Those congestive heart failure, heart disease, utilization of emergency departments, all of that adds up. So sometimes remind folks there's a cost to inaction. If we don't do this, there will be a cost there too. And I guarantee you, I assure you that it'll probably be a higher cost, because usually that cost comes at the cost of a human life or life years. That person, so you, instead of having a mom who lives up to 100 years old, she only lives up to 73. So it does matter. So if I can only stress that enough, I think, again, these policies are kind of like babies. They got to be nurtured. And you got to be guided all the way through. And it matters a lot to our communities that really do that. All of us have to fight for this. All of us have to speak out, even if it's just a voice. If you go on votervoice.net and you say, hey, let me just tell you, I live in this area, and this is important for me. And you don't have to have very verbose words, the greatest, vocabulary. Just say something, because the more buzz we create, the more the folks at CMS will say, oh, there's a lot of people, they're concerned about this. And
yeah. Well, you heard it, folks. I mean, Dr. Serrano, who worked at CMS, also, I would say I also worked at CMS. I was at CMMI. I will also underscore that they do pay attention to the volume of letters. And so that's why we're here today, to say, not just, you don't have to be someone living with obesity to advocate for Medicare coverage of obesity medications, right? Just hearing the arguments today that this is about making sure that all of us have a healthier future. And sometimes we use that terminology in a very just casual way, but you heard Dr. Serrano, you've heard Dr. Kane, you've heard Sherry comment about, just about the quality of life, about living longer, about having opportunities to provide for your family, to provide for yourself, to work and be productive, to care for your children, to see your children grow up. It's amazing how weight loss can change all of that for an individual. And so when we're talking about how do we influence this policy, nurture policy, then it's really just a matter of using that link that we provided in the comments section. It will take literally 2 minutes of your time. If you're worried that you might not have the right words, we actually provide some suggestions for you, and then you can add your own personal experience to it. Okay. Okay. Am I back? All right. So
You're
just
back.
to wrap up, provide this link for you. It takes under 5 minutes. You could use some of the suggested wording or add your own to click, and submit. And there you go. CMS, the Medicare agency, will have your comment period, your comment. Please, the comment period ends January 27th. Please, we can't stress that enough. Please share the materials that have been provided for you in the comment section today with your friends and family. And we want to thank you for joining us for this conversation.